Into the Legit Therapy Show with Dr. Jibunoh, and today on the show we'll be discussing medical brain drain, looking beyond financial remuneration. So we know that recently in the news, the issue of medical brain drain has been on the tip of our tongues. With the House passing a bill, and then the reaction from the medical associations, and the warning strike and all. And we know that from the response from the doctors was that they had asked the House of Reps or the lawmakers to increase their wages. Okay, if you want doctors to remain here after training for 5 years, increase our wages. But we've thought about it. Is that all we really need? Is that really the solution to this problem that we're facing, or is there more to it? And that's why we've come on air today to talk about it. Medical brain drain is defined as the migration of health personnel from developing countries to developed countries and between industrialized nations in search for better opportunities. So it's a global concern. Not only are people migrating from less developed countries like Nigeria to more Western countries, but even within the Western countries, people also migrate. So you see a lot of people leaving the UK for Dubai or Australia or Saudi. So it's a global problem, and this global concern that we have, poses a threat to health systems generally. So across the world, health systems are threatened. In less developed countries like ours, health systems are not very strong. They're still a bit fragile, so they're even more threatened than in the West. For the West, it's manpower shortage because they have an aging population, so most of their population are quite elderly, so the youthful population are quite sparse, so they need immigrants to come in and fill in that space, compared to here where we have over 60% youthful population. So we have a lot of young people but not actively engaged. So this medical brain drain poses a threat to health systems across the globe. It also poses a big threat to patient safety, because when you have manpower shortage, you don't have enough health workers as you should. Of course, there's a threat to patient safety, there's a threat to avoidable deaths and preventable deaths. So you find that in places where you don't have quick access to medical care or medical personnel, deaths that could have been avoided or quickly addressed are left to linger. So we lose more. There's more morbidity, there's more mortality because of this issue. Also, medical brain drain exacerbates inequitable access to quality care. In places where the health workers still remain, you find that they aggregate around certain regions, certain areas in the cities, in the urban regions. So the rural areas are left without health workers, and of course, there's the access to good quality care. Because there's a lot of inequity in terms of that. So you find areas or regions where people barely have access to medical personnel, or they have to wait for once a week or a certain day of the week for a medical personnel to show up. So those kind of situations put people at risk for preventable death. Also, it weakens the profession as a whole, because you find situations where you need a team of workers. Not only doctors alone do not form the health force. You need doctors, you need nurses, pharmacists, lab workers, it's a whole spectrum of health workers. But when you find there's that shortage, you find that when there's supposed to be a doctor to a certain number of nurses, there's a shortage, and that weakens the profession as a whole, because the healthcare professionals in those situations are not able to practice as they should. Then we'll not move on to the factors that are propagating this issue. We talk about push and pull factors. There are push factors from countries, from donor countries where people are living en masse. There are certain factors which you call push factors that are pushing them out of these countries, and then there are pull factors that are pulling them into the destination countries. Certain factors attract them into these destination countries. It's a phenomenon that has existed since the 1960s in Nigeria. People that left the shores of Nigeria to go and study abroad in the 60s, a lot of them didn't come back. And it's something that's been going on for many years. So it's not new, it's not unique. What is different about it now is that the numbers have increased massively, not only within the medical sector but across all sectors. The IT sectors, the banking sector, all sectors are losing manpower at a very rapid rate. And the problem is that we don't see the effect in the immediate term. The effect starts to show on the short and the long term when we find it difficult to fill the manpower void or the gaps. So now moving on to push factors from donor countries. Countries like Nigeria, other African countries where people migrate from, we see that there's poor financial remuneration for health workers. When you compare salaries here to salaries in more developed countries, high income countries, there's a massive difference. So we say there's a 10 times increase in salary in those high income countries. So assuming a doctor here hypothetically earns 20,000 naira, in a Western country you earn 10 times that 20,000 naira. So you can see that the difference is massive. And then with the exchange rate, by the time you convert that money, looking at what the rates are, it's crazy money, so who doesn't want a better life? So those are some of the push factors. Well, nobody was born to suffer, so that's one of the factors, one of the attractive factors, one of the reasons why people, one of the push factors we see from less developed countries. Also, in less developed countries, medical workers are overworked. A lot of their colleagues have left, and there's no one else filling the space. So you find that the work that should have been spread out to 10 people is now covered by maybe 3 or 4 people. The workload is more. You can have as many as 100 to 200 patients lining up just to see 4 doctors. It's crazy. It's that crazy. So that is, the doctors are overworked here. The shifts are crazy. There are long shifts, and hazard allowance are very poor. So if on those shifts you get into any problem or there's some issue there, the allowance you get to fix that problem, that wound or that trauma that you have faced is very minimal. So you put your life at risk for very minimal remuneration. So it almost seems like it's not worth it at the end of the day. Also, there's very minimal support for research. What is medicine without research? Medicine cannot exist without research. A lot of the advances we've seen in medicine today are because of researches that have been done over time. When at the advent of medicine many years ago, a lot of drugs that exist now, a lot of treatment protocols or equipments that exist now did not exist at that time. But because of frequent research by health workers, when they see a certain number of patients coming up with certain conditions, they do research, they create vaccines, they create equipment, and that's why we've seen the advancements we've seen over time. But because a country like Nigeria continues to be a consumer nation, we consume everything. We hardly produce our own. We consume from others, so we wait for others to produce and we consume, which is it's a terrible culture, because we have the capacity to research as well and produce and create as well and offer and take our own research to the world. Because sometimes when you tap research from other countries and those researches were done on Caucasians or people from other races, it might not be you can't easily transfer that on a black population. You might have to redo the research again on a black population to see if the effect is the same. So the fact that there's really minimal or no support for frequent research is a downside or a push factor for a lot of medical professionals. We also have very poor working conditions. You go into hospitals, there's no lights, there's no AC, the doctor is sweating, and all kinds of things. There's a foul smell. The working conditions are not that optimal. These are some of the reasons. And then there's the insecurity. Recently I spoke with a friend of mine who is a medical doctor, and her husband is also a medical doctor, and then he, because of his love for the rural community, he went and opened his clinic in a very rural area in his state. Let me try and see if I can take care of people in the area. And you won't believe that this man was kidnapped from his hospital. He was trying to help people in his community, and he got kidnapped. And guess what? By the time they released him, they had to pay a ransom and all that. It was such a traumatic experience for the entire family. But by the time they released him, within 2 months, he was out. He jackpot immediately, and now he's somewhere in Saudi, just living his life peacefully. Shut down the hospital and just jackpot immediately. So for some people, maybe they didn't even intend to jackpot, they wanted to give back. But you find that because of the insecurity that we face, they are left with no choice but to, leave the country. And then surprisingly, there's a large unavailability of jobs. There's mass unavailability of jobs. We throw out doctors or health workers every day, but you find that they come out and there's this lag. There's this period where they are searching for work. There are not enough practices, not enough private practices to absorb them. The government hospitals say they are fully congested, there's no space. So for some of them, they come out, they're waiting, they're looking for jobs, and you're wondering, why did I go and study medicine or nursing and come out at the end of the day, there's no job waiting for me? And for some people, that prompts them to start to write foreign exams, and they're on their way out. People that get comfortable are people that easily get jobs. People that come out and get jobs get comfortable. They say the comfort zone is the enemy. So you come out, you get comfortable, then you have no reason to jackpot. But when you come out, there's no job. No, nobody's going to tell you. They're going to start writing all the exams, and you're going to find a way to leave as quickly as possible. And the fact that the political will to improve the healthcare system is also a discouraging factor. Our politicians can afford to jet off at any point in time to get healthcare anywhere in the world, but the average man, the man in the lower and the middle class, they're not privileged with that opportunity, and the majority of our population fall within that category, within the lower and the middle class. So it's important that we service the lower and the middle class, and in order to service that population, we need to improve the healthcare system that exists on ground, because not everyone can hop on a plane and travel when they need healthcare. And who even says that the person that wants to hop on a plane can get to if there's no healthcare professional to help you get on that plane, how do you even get to the country that you want to get treated? So it's important for us to improve our own, to look at the faults, look at the deficits that exist in our system and improve them. Pumping the finances we need, pumping the manpower that we need, and make sure that we take it to the next level. Also, training and availability of training slots. Doctors come out, the opportunities for further training, the residency programs, the slots are very limited. For some programs, you hear in the country where you throw out maybe over 2,000 doctors or 3,000 doctors per annum, you hear that there are only 5 slots for a particular specialty, and you're wondering, how do you provide only 5 slots for over 2,000 doctors? It's crazy. So when they go for those exams, over 2,000 doctors are writing the exam that you're going to only pick 5 people from to get it's almost ridiculous. So there's so many discouraging factors. And lastly, I'll talk about the way the health system is so poorly coordinated. It's not one, it's not unified. So everyone is just working in silos. The general hospitals are here, tertiary hospitals, private hospitals, primary health care, but it's not coordinated. It's not. Emergency care should be coordinated with these general and tertiary practices, so that people can. It's easier to triage people from one level of care to the next level. The coordination is so poor, and it's something that really needs to be looked at. So these are some of the push factors, some of the frustrating factors that push medical personnel out of this country on a daily basis. Then on the other side, for the destination countries, they have pull factors. You can see how the UK came out with a law that they don't want dependents or people that are coming to school to come, and immediately Canada just capitalized on it. Sorry, your loss is our gain. Please come with your dependents come as well, because there's a gap. They have so many old people, very few young people. They're old. There are people that the population is, because of the good healthcare that they have. People can live long. People can live to 80s and 90s, but because they are old, they can't really do most of the hard work. So they need young people to come and do the hard work. In Africa, we don't live that long because the healthcare is not good. So you see the differences here, and they are ready to fill that gap. Please just come, because we need more young people on this side. So they are ready to capitalize. So I guess it's going to be difficult to say, as much as WHO brings out the red list and puts Nigeria on the list, once one country closes their own border, another country will open, because it's a global problem. In Saudi, there are so many African doctors in Saudi, in Dubai, in Australia, everywhere, New Zealand, some islands. People are going to some islands and Barbados, people go everywhere, because health workers are needed everywhere. And the factors that attract them to these countries include things like better remuneration. So you get there, not only do you receive your salaries, they're paying you per hour, they're giving you housing support, there are incentives, allowances, they will give you credit. Okay, you are supposed to collect take credit and start and leave, and then start paying when you earn. So many things have been put in place to encourage people to survive on those sides. So why not? Who wants to suffer? Why not go to where life is easier and survive? And then the working conditions are better. You get there, they put in certain conditions in the workplace to ensure that you're, at least you get there will be AC in your office, you know, or you'll be sweating while you're consulting with patients, you know. There are certain measures that have been put in place just to make things easier for you while you're on the job. And over there are clear career paths, you know. You don't have limited slots like we have here. They have more slots, so you're there, you're able to tap into trainings, there are continuous medical improvements, education, continuous development program, professional development programs. So while you're on the job, you know, trainings are coming up every time. Sometimes you don't even have to pay for these trainings, you know, and you can see your career just improving as you get trained. You know more, you're more empowered, you feel like you're moving forward, you don't feel stuck. And then there's job security over there. So a lot of times you go there, you probably start off with a contract, so you know that, okay, I'm starting this job, I'm here for 5 years. After 5 years I can move on to something else. During that 5 years I'm going to encounter so number of trainings. So after the 5 years I know that I'm going to be a better, an improved version of myself. I'm going to be more marketable, you know. So those are the things that encourage or pull people to Western countries. So these are the things that our lawmakers need to put into consideration. The factors that push people out and the factors that pull people in. These are very, very important for us to consider. According to the stats, so going through the research, we found out that according to a 2022 study by Adiba et al., we have a global healthcare workforce of 65 million people. So globally across the globe, across the world, we have 65 million health workers, be it doctors, pharmacists, nurses, lab workers, and other professions. But still, even with that 65 million, there's still a deficit. There's still a gap of over 15 million. So according to WHO and other international bodies, it says that we still need to produce more healthcare workers to fill the deficits that we experience across the globe. And even with these deficits, there's a cross maldistribution scene. So there are more workers in certain parts, and some areas they're less, so it's not equitable. Some countries, like some really small African countries, will have one doctor for so many people, you know. They have very few doctors in their countries. It's crazy, you know. This gross maldistribution is seen globally across the world, and it's also been documented that 15% of healthcare workers are practicing outside their country of origin. So outside the country in which they trained or where they got their first professional qualification, 15% of health workers practice outside the country. So it's not unique to Nigeria alone. You know, even in the UK and the US and other developed countries, a lot of people will still live there for greener pastures. And coming home to Nigeria, we can see that over 2,000 doctors leave Nigeria every year. 2,000 doctors. That is amazing. That is just amazing. That is a large number, you know. At the end of the day, I hope we're not stuck with traditional healers, and but at the end of the day, now we just see one traditional healer put on the stethoscope, and that's the only option. I hope we don't get to that point, because very soon that might be the story if we don't stem the tide now, you know. And then there's always a loss, and I'm sure that's why the government is considering and looking into it now, because there's also a loss for the government, you know, across the world, especially in Africa. Medical care is subsidized compared to Western countries. To be a doctor in the US, to train as a doctor in the US, you practically take a student loan. When you become a doctor, for the next 20 years of your life, you're still paying your student loan. You know, you take another loan to pay your loan again. It's ridiculous, you know. But in African countries generally, it's a bit subsidized, so we don't pay as much. So somehow the government subsidizes that, you know. But now I feel what we're seeing now is that the government feels like they're not getting their return on investment. Every investor wants to see a return on investment, and certain countries have done their research. So countries like Malawi have seen that they lose $2.16 million, you know, annually from their from doctors, not just doctors, sorry, from health workers that leave their country. There's a loss of $2.16 million, and even South Africa alone has quoted an estimated $1.4 billion in terms of estimated loss of healthcare workers. So when the healthcare workers migrate out, in terms of the loss to the total economy, it's in billions for a country like South Africa. We don't have the numbers for Nigeria, but I'm sure that we're definitely making, for there to be 2,000 doctors living there annually, well, obviously, because this is our creative people, these are brains that could have stayed back and giving ideas and improve this economy, but we're losing them to other countries. Now they go there, they give their sweat, they give their brain, they improve those places, they pay taxes. These are losses. So really, we need to look at this as a big concern and look at ways to mitigate the financial loss on the country. Before I'll move on to recommendations for the country and things we can put in place, because countries like Malaysia, Mozambique, Taiwan, South Korea, and even Rwanda, they've put in programs to reverse brain drain, and these programs have included things like incentives. They've incentivized their healthcare workers, so housing support. So you see there that they build houses, and when they build those houses, it's okay, these houses, this quota is for healthcare workers. Let's give healthcare workers the opportunity to purchase houses. You'll be amazed at how people can work for years. I might not be able to even buy a house in this country. It's crazy. How do you save people's lives? You're saving the lives of very rich people, and then you can't even afford to do certain things for yourself. Doctors' children are thrown out of school sometimes. Nurses' children, healthcare workers' children are thrown out of school because they cannot afford to pay school fees for their children. The principal is not going to remember that when I had malaria, the doctor advised me to go and take Artemether. She say, sorry, you have to pay your children's school fees. So these things are things we need to put into consideration. I know in the past, they used to treat doctors like gods. They say in the villages, when you treat a doctor, they will bring cow for the doctor, trade by barter, they will bring this, they will bring that. That was incentives. It wasn't a bad thing, it was incentives, because not everyone can study medicine, not everyone can be a nurse. It's not they're not easy professions. These are professions that take a lot of hours. You work shifts. They call essential services. So public holidays, when everybody else is sleeping in their homes, doctors and nurses and lab scientists and they're all at work. When there's COVID, these people are at work. When there's Ebola, they're at work. These are essential services. It's like the professions that people have dedicated their lives to help humanity, but they're not getting that. They're not getting that. They're not getting that remuneration. They're not getting incentives for it. It's frustrating. Why not gravitate to societies where these incentives exist? So these are things that countries like Rwanda and Malaysia and all these other countries are putting into consideration. Housing incentives, schooling incentives, health insurance, credit. They create special programs, credit facilities just for healthcare workers to improve their lives. These are things we should start to consider as a country. We shouldn't just think of just a one-way approach. We think of, when we create policies, we think of the pros, the cons, and the unintended consequences. So these are things when you sit and weigh policy across these domains. Okay, this policy we're trying to create, what are the advantages? You weigh them, put them down. What are the disadvantages? You put them down. What are the possible unintended, the consequences we did not anticipate that might come up? You put them down, and then you put in measures to mitigate the cons and the unintended consequences, and then create indicators to assess your progress as you progress when the policy gets passed or the bill gets passed. These are things we need to put into consideration. But also, these countries have increased training to boost their healthcare workforce. No healthcare worker would like to be on a job for 5 years and not get any form of training. There's no healthcare worker. You are in the job to get better. The more training you get, the better you are at your craft. So nobody will be comfortable with the fact that there are no training slots, limited training slots. So they are working, but they're not getting trained. Countries that are serious have looked for ways to increase training opportunities for their health workforce. There's also been knowledge transfer programs. So these countries would collaborate with high-income countries for knowledge transfer programs. High-income countries have gone way ahead. They're doing non-invasive surgeries. They're doing cancer care has gone to another level. They're doing so many things. Now, they can, as a country, they can form partnerships, collaborations. The US and Rwanda have done it. The US and Rwanda have collaborated to create centers of excellence, world-class facilities in Rwanda, and then get those health professionals from the US to come and train the locals on how to carry out those procedures. They train them for a period of time and leave them to carry on. These are knowledge transfer programs that can be instituted. So these are some of the things that have been done in the countries I mentioned above. But we have invited an expert on the show. We'll take a quick break, and when we come back, we'll introduce the expert we have with us, Dr. Benjamin Olowojebutu, the NMA chairman for Lagos chapter. I hope I said that right.
Yes, you got it right.
So he's the NMA chairman for Lagos. Welcome, sir.
Thank you, Dr.
Glad to have you on the show with us today.
I'm happy to be here today.
Yes.
Good work you're doing.
Thank you, sir. Thank you.
So we
know. Okay, we have a call coming in. Please hold on. Okay. Good morning.
Hello.
Good morning. You're tuned into Law FM. Good morning. May I know your name or where you're calling from?
Good morning, madam.
Good morning, Mazi. Thank you for calling.
Which sport is it that doctors are applying out of the country? These people have been trained and they which part of the government? Yes. Or the part of the doctors? Why are we always like this? Teachers are not taken care of, doctor workers are not taken care of, and every other crisis in Nigeria. And the local service they're not feeling it as a concern. These people making laws that they should not go or they should work no too. Are they patronizing Nigerian hospitals? Are they patronizing Nigerian med products? They were all trained here, taught by public schools, and now they don't find it relevant to upgrade these places they came out from. No, our government is not doing too well. Government should give an every crisis to make sure that these people, they go out of the country, still come back. Not that we out of the country now, because the country is not doing well. Don't just have to yourself and everything at the end of the day, don't just talk to us. 5 years, you can't give just a doctor and be working for 5 years. There's nothing to show for it. Something has to be done.
Thank you, sir, for your comment. Thank you so much.
Thank you.
Dr. Olowojebutu says, whose fault is it that doctors are jackpotting?
That's a very, I think it's a very passionate Nigerian, and he has seen it very clearly. I say that the government, the people that and the ruling class have not owned the process. If you're a leader and you own the process, you give confidence in the process of the healthcare space. For example, if we have the local government chairman go to the local government primary healthcare center and use it as a point of use, and their co-workers say that this is where this guy checks his blood pressure, he goes to check his blood sugar there, then it makes the primary healthcare center very popular and people can begin to use it. So the politicians, the healthcare, the ruling class should own the process. Not like you have a headache now, the next thing you're taking the next available flight abroad. You don't own the healthcare process in Nigeria, so you're not improving it passionately. So the money you're supposed to spend in Nigeria or those healthcare spaces that you're spending outside the country, you're improving your own economy. You're not so it has to be a balanced outlook.
You think is that they don't trust us, the healthcare professionals, that maybe they feel that we are here, we don't know anything.
I don't think they don't trust us. I just think they don't want to own the process. They don't feel like empowering the process, because you can't say you invested in the education of medical doctors in Nigeria and you don't trust them. If you don't use them, how do you know you're trusting them? That's the point. At least we heard that the past vice president used the hospital in Lagos for his orthopedic surgery. For me, that's like a patriotic Nigeria. So you have given validation that this process can also be done in this country, and we can also get value for it in this country. The idea is that our ruling class are not owning the process. It's very, very key. Because first things first, we have to begin to, as I said earlier, give incentives to those that want to live and stay in the country. For example, it's not just medical tourism abroad. There is an influx of doctors or healthcare workers from rural communities to the urban, because where they are, they cannot enjoy the full life. They cannot enjoy there are no special amenities, no water, no good roads, no education for their children, and they want their children to look like other children in urban areas, so they're going to move. So what happens to those communities in those places? What I've said in the past, I'm sure in 1999, General Obasanjo retired, did a program called MSS, which is a midwife skill scheme, where retired midwives in urban communities go to rural communities and help them do primary health care, take deliveries and stuff like that. But Boko Haram setting and bandit setting, so people don't live in the place because nobody could guarantee their security. So the empowering of having proper health care, proper amenities, proper social impact, and owning the process is important for government, and that is government function, because the right of health, right to education, right to social amenity is government. Yes, is government duty first. So that gives room for healthcare workers to, okay, I'm safe, I can stay here. I'm sure you've heard about doctors going to do ward round or going to do night duty, and they were never killed on the road. So what gives guarantee to those doctors that if I go to this community, I'll be safe? Those things are important to give guarantee for healthcare workers to stay back in this country and improve access to healthcare in Nigeria.
Very right. We have a text that just came in. He said your guest spoke about the goal of the healthcare system, but he didn't state categorically the actual goal. Maybe if we know the actual goal, they'll be able to actualize it. Thank you. So the healthcare system as a whole, when we talk about the healthcare system, we're talking about the tiers of healthcare.
So healthcare system, basically,
the way it should be structured.
It should be structured in very, very simple, as it's been done since, in 2021 we had an Abuja convention that says minimum of budget allocation to healthcare should be 15%. And since that 2021, 23 years after, we're still at 6.5, 5.6%. So adequate funding is not even there.
Yeah, true.
Number two is, how are we diversified and accountable for this sphere of government? Primary healthcare system, secondary healthcare system, and tertiary healthcare system. How far as government have been accountable to this primary healthcare system? For example, I'm sure your locality, you might not know where the PhD is, because one, is not popular, it's not well funded, it's not well situated. People are not using it because it's not popular. Now it's because the funding, the funding of healthcare system in that primary healthcare system is not evident. One, and people are not using it because it's not very meeting the needs of the people, and it's not available. So availability is very, very key for the PhD. Sometimes you see they're already moribund, their grass is growing, there. You have no equipment there. So people that have malaria and typhoid do not go and sit down in Luth or sit down in Lassuth and say they want to see a doctor. So you're overburdening the specialist center to be treating very primary care issues.
Very true.
So what I expect the government to do in this new dispensation going forward is, our National Orientation Agency that used to do a lot of work in the past, and talk about each sphere of government and what the work they should do. That the populace should know that if you have malaria, if you have typhoid,
does that agency still exist?
I hope that still exists, but I've not heard about it in a long time. That's what I should be doing. That if you have malaria, if you have typhoid, go to the PHC. There's a doctor there for you. There's a nurse there to see you. Don't go and be wasting time or waiting on the queue in Luth or in Lassuth, which is the problem. But because people don't understand that these PHCs are available and they're functional, and they should be functional. Some are not functional, and the access to them. Somebody lives at Olayinka and is going to see a doctor in Ikeja. Look at the distance. Or lives at Olayinka, goes to doctor in Lekki.
You can't even make it there.
You can't even make it sometimes. So for me, first things first, let's solve the primary healthcare issue in this country. It's very, very key. I heard we have about 775 primary care centers in the country, but how many of them are functional?
Yeah, you're right.
How many of them are equipped? How many of them are functional healthcare workers? I get it. And I said clearly that we must have a doctor-driven PhD center. Most times we have Chew, back in the days it used to be Chews and Chews.
They're still there.
They're still there. That it was running the PhCs, and they're beginning to make decisions that the doctor should make that affects the quality of life of the patient. So as a government, we must have a doctors-driven PhC that the doctor understands, and we have to expand the PhC. When you have mental health coming to the PhC, when you have primary screening of cancer care coming to, because you see across board
specialties.
Can I shock you? Somebody goes to hospital or go to a PhD because the people that they see are not medical doctors, they're not trained in that area, lose those small details of symptoms that they have, and they say it's malaria and typhoid. And somebody that have cancer for almost 3-6 years
that could have been
seen at the first stage. So it's important we expand our primary and make it doctor driven and add primary screening of cancers, mental health in the primary, because especially
maybe PPP might be the solution to the problem, because maybe getting organizations, CSRs, partnering with.
I agree with you.
With this center, so
Yes.
they adopt health centers
Yes.
and equip them.
But we have to have a functional accountability too. The problem I've seen in this country is that we get donor agencies, we get CSR, but nobody's accountable for it. Can I shock you? All the beds that were given to us during COVID, where are they today? Do you know? No accountability. People made, some companies made very, very big centers for COVID. Where are they today? We don't know. So the point is that even when we get these donor agencies to support us in our healthcare system, there must be a clear accountability and also outcome measure system. So we know this is the input before and this is output now. We have done what because we have done this, and this, and we've gotten this particular thing and we are accountable for it. So that people can own the process. Because what happens in this country, we don't own the process. People think when they get into power, it becomes, I have arrived. They forget the common men. They forget the people that have worked hard. For example, it's not only, as I said, in Rwanda. I read about Rwanda even in South Africa. Zimbabwe is trying to adopt it now. That every doctor that finishes from medical school gets a small flat. So imagine a doctor that finishes medical school gets a flat. I know, okay, I don't have to pay for rent, but they take out from my salary every month. They don't have the impetus to leave the country because they have something they can live to. There's comfort.
Yes.
So for me, it's about understanding that there's a measure of elasticity. Hooke's law says that force is directly proportional to elasticity. But when there's an elastic limit, what happens? There's a breaking point. So people are
burning out. So jackpine immediately.
But can I shock you, James? Can I shock you? Before, it used to be younger doctors that are jackpine. Now you have all the guys. The professional, the trainers, the specialists. They're supposed to train upcoming doctors, upcoming healthcare workers. They're leaving the country.
And they're going to start again. They don't care anymore.
Because the environment is toxic to them. They're burning out. Somebody I lost a friend that did multiple calls in Ebonyi State, a gynecologist. He died doing surgery because he was burnt out. He did multiple calls in 3 days, died on the 3rd day. So who cares about the family? Who cares about the children? It's gone. And we must have and I ought to have a government that understands that when people work hard, they should be compensated for working hard. Another idea I have is simple, is that if people say I want to work in rural community, I want to stay in this rural community, there must be incentives for staying there.
True.
There are villages that in Nasarawa, can I shock you, they have about 150 doctors in the whole of Nasarawa State. In Taraba, about 200 doctors in the whole of Taraba State. So if they get opportunity in Taraba to get a job in Lagos, what would they do? They will run. But the people they are serving in Taraba State, what happens to them?
There's a deficit.
There's a deficit. So it's not really about medical tourism or medical jackpine to the abroad. It's also within the country.
And even doctors, medical practitioners leaving medicine for other professions.
A lot of them are doing that.
That's happening too.
Because it's born out. It's not encouraging. There's no joy anymore. There's no joy. You know that nobility of being a doctor. That you, as I said, you are seen as the Surgeon General in Nigeria. Nobody talks down at you. You are respected. You are given value.
You save lives.
You are passionate about giving of yourself. I've seen doctors donate blood for patients and still go back and operate the patient. That's what the work is. But nobody is giving them that value. The budget for Nigerian healthcare is about 5.6%.
Very low.
Very, very low. Instead of 15%. And somebody has ear pain and leaves the country with taxpayers' money to the abroad. And so because of ear pain, you go and do
not only do they need to increase the budget, it needs to be better allocated.
The point is this.
Those things need to be, I know the VP that just left created a health reform a report, I don't know what the content is.
That's the point. But how much have they involved the healthcare practitioners in these health reforms?
So because he's a lawyer, so I hope there were health practitioners on the committee.
So you make an health reform for doctors, for for scientists, for nurses, and you don't involve them in making the law. It doesn't work that way. Doesn't work that way.
I hope, but we hope that we're starting this conversation, and we hope that the government is able to. We all need to take health needs to be prioritized. Really,
Yes.
Government needs to shift their mindsets. That feels like, in terms of medical education, the health workforce, and even the health system, they're seeing it as a cost, but it should be seen as an investment.
Social investment.
It's an investment.
Correct.
Because when we invest in healthcare, we create quality healthcare workforce, which creates a solid healthcare system. And at the end of the day, we reduce morbidity and mortality, we reduce preventable and avoidable deaths, and we improve the quality of the life of the people. And once we do that, of course, productivity will go up.
That's it.
The economy goes up as
GDP
well, because people are able to work.
Correct.
People are healthy and able to work. I must also add that we have a large number of unemployed youth. We can push a lot of youth to healthcare. One problem we see now, we see the limited slots. Oh, you see 1,000 nurses writing nursing exam, but they're going to just pick 50 of them or something. You see 1,000 medical doctors going to medical, they pick a small number. We need to increase those numbers.
Can I shock you?
We need to increase the numbers.
Can I shock you, Jibs? We have 3,000 medical graduates every year, and we need 10 years to produce 3,000 medical doctors to be able to accommodate what we need as doctors for this country. Out of our 3,000 that goes out every year, at least 1,000 of them leaves the country immediately. So what I've said is very clearly, we need to improve numbers of universities producing graduates in Nigeria.
Yeah, true.
Then also
increase the space,
the quota. Let's have more people enjoy being medical doctors,
and nurses and labs. Yeah.
So we have the adequate numbers.
People that we are pushing to microbiology and biochem, all those things, push them back. They wanted to study medicine in the first place. We're pushing them to other courses. We need them. We need medicine. We need them. If they start, if they do well, they make it through. If they don't do well, they fall out.
When you increase the allocation on the budget, all this will come into place. Is important. Government must be willing, must be willing, must own it. Let's finally push this budget 15%. Things will get better in this country, I can assure you.
Yeah. Okay, so just a few take-home tips. Just take-home tips for us. We talked about strengthening the healthcare at the primary, secondary, and tertiary level.
Correct.
We thank our late Prof. Oluwojebutu and some Kuti for even starting primary healthcare in this country. And that's why we see where he started is where we stopped. Because he was a pediatrician, he focused on child and maternal care, and that's why the healthcare facilities,
that's what they do.
Vaccines, that's what they get at this level. But we need to go beyond that, proper triage, like you said, National Orientation Agency for proper triage. People know where to go, what kind of illnesses to take to primary care, secondary care, tertiary care. Very important.
And the referral system has to be sorted.
And it has to be sorted. It has to be more. We have to have a more coordinated system. Well, thank God for the emergency numbers we have now. You call the emergency numbers, they tell you where to go. You're triaged to those places. We need centers of excellence. We need big facilities that cater to specific illnesses like cancer, trauma. Like a cancer center, like trauma center, stroke centers. People die from stroke every day. We heard about a popular Nigerian that just passed on a few days ago from stroke. People die from stroke in this country every day, but if you go abroad, people get stroke and live on for the rest of their lives.
I have multiple strokes.
Oh my God,
7 strokes, 8 strokes.
People have one stroke and that's the end. And stroke is not a respecter of person. It can hit anybody at any time. So these are things that everyone has to put into consideration. Centers of excellence, we need to create the centers. Also, healthcare financing has to be prioritized. People pay out of pocket for healthcare. Sometimes it's catastrophic. Some people have to sell. I did some research in cancer care. People were selling their houses, selling plots of land to pay for cancer care. Some of them still died at the end.
We hope that NHI has now been domesticated in Nigeria. NHI, now National Health Insurance Authority, will accommodate cancer as part of it. Because
it's expensive.
Because the rule is that everybody that breathes air in Nigeria must be part of NHI. I hope they can domesticate in every state, so we can get more funds in insurance.
Yes, that's fantastic. So financing must be prioritized, and like we said earlier, we must increase the quota. Let's push more so many unemployed youth. Anybody can be trained as long as you're intelligent. We can train you to be healthcare workers. We have different cadres in healthcare. different cadres. We can train people. There are doctors, there are nurses, nursing assistants. If you go to America, they have so many cadres, and they're able to all contribute to the workforce. We need this. We need to look at. Let's not look at it that when somebody child gets into nursing school here, they throw a party because out of 1,000, they give testimony. They say out of 1,000 people, only 10 people were chosen, and she was one of the 10. I was jubilating. Well, it's a ticking time bomb. At the end of the day, we need more people in the profession. Dr. Olowojebutu, thank you so much. We run out of time. We wish we could continue this conversation.
Thank you
Thank you so much for contributing to our talk. This is the NMA chairman for Lagos. Thank you so much, and we hope to have you again on the show.
I'll come back
at a later time.
Hopefully there will not be first. I'll come earlier.
Thank you so much. And so till next week, Wednesday, 11 a.m., remain the legit therapist on Law FM 103.9.